Moving on to our next topic in this idiopathic interstitial pneumonias, we have Dr. Dharm Prakash sir from Department of Pulmonary Medicine in JIPMER. Sir is the additional professor and head of department. And sir will be talking on the second part of this idiopathic interstitial pneumonias, namely the smoking-related IIPs, namely RB, ILD, and DIP.
Just hang it, sir. Do you have a pen drive with you?
Yeah, pen drive with you. It is hanged. So during this technical glitch, I would like to thank the organizers to call me here. And it's wonderful to see this new campus actually. This is the first time I'm coming here. And it's really, I've visited many, but this is one of the most, well-structured and well-thought of campus. So I'm blessed to be here actually today. So today's, we are going to talk about ILDs and idiopathic interstitial pneumonias. So the largest one is covered by my previous speakers, IPF, and a few more are there which are related to smoking, and I'm going to discuss about it. It's going to be short. You can start the timer, sir. So smoking-related ILDs, are why they are clubbed together. Why it is called smoking-related? Because the common factor is smoking. So it includes RB-ILD, destructive interstitial pneumonia, and PLCH. And the common factor is smoking. So this. Something else is coming. I'm not able to read. Okay, fine now. That's fine. Something else was coming actually. So this something is. Anyway, so this Venn diagram is taken from a paper which was published in Chest 2003. So in this author, what is happening? That anyway, so in smokers, the presence of respiratory bronchiolitis or bronchitis is there universally. Around 20% will develop emphysema, and a few will develop ILD, those who are having DIP or PLCH. No, I'm not doing anything. I won't touch it. The pointer is this. Pointer यहाँ है, आगे पीछे.
आगे पीछे काम नहीं करेगा सर.
Right. It's still running with this only. Okay. So these RB-ILD, DIP, and PLCH, they form a spectrum of interstitial pattern of lung injury due to cigarette smoking. So this is my first case. A 15-year-old male who presented with 3 years of cough with wide mucoid sputum and no hemoptysis, breathlessness, exertional for 6 months, a grade 2 MRC, and he was able to walk up to 1 kilometer. Is current smoker with 20 BDs per day for last 30 years and alcoholic. On examination, he was vitally stable. SpO2 was normal. Nothing on chest X-ray chest examination or systemic examination also normal. And in X-ray, you can see a little bit of nodular shadows, a little, nothing particular. What to do? You have any other thing to attach to? In hair junction. It's connection only. Even normal चल जाएगा, कोई परेशानी नहीं है. तो प्रेजेंटर भी उसे हो रहा है.
हो सकता है सर. सर डीजे सर को भी सेम प्रॉब्लम.
Okay. So, no, it's just this HDMI cable. HDMI is, yeah, it's not coming here. Okay. So as we see, some nodularity is there in chest X-ray, but we cannot comment actually totally on based on chest X-ray. Other systemic examinations were normal, and this is exclusive for this. Or can we have something? I don't think it's laptop. It'll continue. I don't think it's laptop. I don't think.
No.
It's your laptop. How it can be? I think it's cable line. Because communication with this is not happening. Other things is coming actually. Dr. Irfan, you can pause that.
Space bars.
This gives tension.
We'll connect this.
You change it totally here.
If this works, then it is a problem with the laptop. Other remove one. Put on that. No. Put on that. But this also hasn't come.
No,
This detected.
It will take time.
It's coming. But it's not coming here. Open.
Scanning. Scanning it has got
You can use the mouse.
just to copy and paste.
You can use the mouse.
This?
And that also.
Okay. So we were at X-ray. So this is the HRCT of this case. I want to pause. Oh. So if you see this CT, HRCT on the patient, so there are some nodularity, centrilobular in location, and these are not very well formed. These are like diffuse and not very, like real nodule. It's like a doubtful nodule kind of thing. You can see here, and in the previous sections also. So I'll run this again. Sorry. So can you see these small nodules which are centrilobular? So, with central lobular nodule in a smoker, the report by the radiologist was a diffuse central lobular nodules with some ground glassing in bilateral lung field and more in upper zones. Relatively, it was sparing the lower zones. So, probable diagnosis is RBILD. And there was another airspace which was probably diverticulum of trachea. But for central his PFT showed mild reduction in FVC, FVC1. Ratio was preserved rather high, and DLCO was also mildly decreased. His 6-minute walk distance was little low. He didn't desaturate while doing it. So, how many places? So we come to the differentials. So most common causes for central lobular nodules are infections. Then we have to look into the pictures of fever. We can go ahead with the BAL, pyogenic culture, CBNet. Hypersensitivity pneumonitis, there will be exposure history. If you do BAL, you can get lymphocytosis and triple density in CT. Sarcoidosis has got its own feature. Distribution is peribronchovascular, perilymphatic, near septa. Serum calciums are high, and if we do BAL, lymphocytosis can be seen, and there will be increased CD4 to 8 ratio. But this case, smoker is having, if we do BAL, we can find peculiar finding, and usually we don't do histopathological examination unless we have got some strong suspicion for some other alternate diagnosis. So BAL typically shows these pigment-laden golden color macrophages, which is called smoker's macrophages, and the number of macrophages will be more. But it's not very common to find the other entity will be having more in BAL. So if we do HPE, and then this patient, we didn't do even BAL actually in this case because of smoking history and typical hazy kind of ground glassing, patchy ground glassing, and central lobular nodule. The working diagnosis of RBILD was made, and he was treated with smoking cessation, lifestyle modification, and symptomatic management for cough. He was not given even steroid. And follow-up after 2 months, the patient was feeling better, so we continued the same, not giving any steroid and anything. So talking about HRCT finding of RBILD, so we have central lobular nodular opacities. So it will be sparing the pleura. Patchy ground glassing can be seen. Bronchial wall thickening, if you can appreciate here, thickened bronchial walls are there. And upper lobe predominance. These 3 findings are suggestive in a smoker of RBILD. And because it's smoking related, you can find some of the areas with emphysema. If we do BAL, we can get this golden color pigment-laden macrophages. Classical histopathological finding is pigmented macrophages, which is surrounding the terminal bronchiole and nearby alveoli, if you can see here. These are the surrounding and inside alveoli also, and there will be peribronchial inflammation and fibrosis. To sum up, RBILD, there is no gender predilection, young age, current of former heavy smoker. Sometimes they present with dyspnea and cough, occasional wheeze and normal X-ray. HSCT, we discussed, centrilobular nodule, which are not very well formed, patchy GGOs, more in upper lobe, associated emphysematous change, and air trapping on expiration, ball typically showing pigment-laden macrophages. The treatment is smoking cessation, and there's no or controversial role for steroid. Most of the people say just smoking cessation is enough. Coming to the second case, current smoker, 68-year-old male. There is no other comorbidities, BMI of 20. Presented with the shortness of breath for 4 months, and there was no weight loss or fever, and there was no history of any exposure to organic dust. This was his X-ray. On examination, he was having, there was nothing on examination or general examination or respiratory examination. Lab investigations were normal only. All parameters were normal. PFT showed restriction with severe decrease in the DLCO. Moderate decrease in the DLCO. And these are the cuts from his HRCT. In HRCT, we can see there are paraseptal emphysematous changes, lots of GGOs, which are encompassing the whole lung. And GGOs are more predominant in the lower zones. This is coronal section. This is anterior and then posterior. If you can see, it is involving more posteriorly, and apical areas are having emphysematous changes. And if you see where exactly it is going, whether we are having okay. So septas are clear. There's no nodules there. So in these cases, we have to again look for the DDs for GGOs. Patient is non-smoker, then you look for subacute HP, viral pneumonias, PCPs, alveolar hemorrhage, NSIPs, and RBILD also can have patchy GGOs. Here, the ball was done, and here you can see lots of pigment-laden macrophages. This is GIMSA stain, so it looks different. He was treated with smoking cessation. A short course of steroid was given, lifestyle modification and symptomatic treatment. He was doing well. So, coming to the HRCT findings of DIP, so we get bilateral patchy GGOs, and it is subpleural and basal predominant, and associated emphysematous changes will be there, but honeycombing is not present unless it goes into fibrosis. Ball is typical, that pigment-laden smokers macrophages can be seen. Histopathology, again, examination is not required. Commonly, it's not needed unless we have got alternate diagnosis. If we do, we find that inside the alveoli, you get lots of macrophages which are pigment-laden, and some septal thickening can be found. Sometimes intra-alveolar macrophages will be filling the total alveoli. So, clue to the diagnosis is a smoker having GGOs, not having any alternate system involvement. So, it's more common in younger patients. Male-female ratio is 2:1, related to tobacco exposure around 90%, and can be due to other environmental exposure, drugs, hepatitis C, also progressive dyspnea. Reduction of DLCO is marked, that is not there in RBALD. Usually have some patchy consolidation. patchy ground glass opacities in HRCT, subpleural and basal predominant. Honeycombing is not there. And on histopathology, you find pigmented macrophages inside the alveolar spaces, and there will be mild or to moderate alveolar septal widening. Again, treatment is smoking cessation, oral corticosteroid, and some of them can develop into fibrosis that becomes fibrotic NSIP. So take home is there are multiple smoking related IIPs, including IPF also. So non-IPF IIPs, ILD and DIP. The common clue is history of smoking, current smoker or heavy smoker. The hallmark is smokers' macrophages. And the only difference is the kind of involvement. RBILD upper areas will be, upper lobes will be more involved, and it is peribronchial in RBILD, whereas it is alveolar in DIP, and because of the different places of involvement, the HRCT pattern will be different. Because it's involving peribronchial, so it is coming as nodule, whereas alveolar involvement leads to the GGO appearance. Smoking cessation is the key for management, and they have got good prognosis. Thank you.
Thank you, sir. We have a couple of minutes for a question or two. Are there any questions from the audience?
Sir, you said the pigment-laden macrophages, they're actually characteristics of all the smoking-related ILDs, DIP or RBILD. So we do BAL sometimes in normal COPD patients or some to rule out infections or some other. So how do we differentiate? Like, what is any cutoff is given for just this cutoff above? We say that it is going towards RBILD or something like that.
There's no cutoff, but actually number of macrophages will be too much in these two conditions rather than a normal smoker. Obviously, smokers, any smoker will be happy smoking macrophages. Dr. Hadda, you want to say something? Yeah.
I think the whole thing is not the macrophages. First, if you are to make it as RBILD, then you have to understand ILD. It is conditioned ILD. And then you demonstrate smokers and you bar. Then your direction is RBILD. But if there is no ILD, and you are taking bar and it is showing this one,
That is smoking.
it is not making diagrams of ILD. But number exactly I think that is can tell, but this is what my